All right, video number 5. Let's talk about EKG tracings. So this is going to be a quick down and dirty of it real fast, and then we'll go into a little bit more in depth. But just to get our bearings straight, we're going to have this SA node firing in the atrium. We're going to see a diffusion of the depolarization in the atria, and we're going to see us come off this isoelectric line with positivity in voltage. And then we are going to go into the left atrium. And this is something that's really cool that I found out that I did not know, is that the P wave correlates to both sides of the atria, the left and the right. We are now going to go into full depolarization of the atrium, where we see the full P wave. We've come back down to the isoelectric line down here. And now we're going to have this, this PR interval, or, some call it a PQ interval, because we are trying to get through that AV node, right? Trying to get through that AV node, hit these, that bundle, go through the Purkinje fibers into the ventricles. But first we have to hit that AV node, right? That AV that's sort of holding everything up. And once we get past that AV node, we're going to see something really dramatic, and that is depolarization of the cells inside the ventricles. So we see these ventricle cells begin to depolarize. And remember, I mentioned earlier that depolarization happens from the left side of the septum and diffuses outwards accordingly through the Purkinje fibers. But what we do not see is repolarization of the atrium. That is sort of masked by this large dramatic change that is measured in voltage from the ventricles firing. So we don't see a repolarization, that repolarization wave of the atria. So we are going to continue with depolarization and contraction of the ventricles themselves, and then we will begin to see repolarization of the ventricles. So that's where this T wave comes into place, this repolarization of the ventricles themselves. Now that's a quick down and dirty interpretation of it. Now we're going to dive a little bit deeper into it for the next couple minutes. So some things to keep in mind when we look through this. We are looking through lead 2 because it's just the standard of how everybody sees it. And this is the correlation of how we're actually picturing the heart, how we're looking at the heart, and how this tracing is being interpreted. Because remember, it's different in all the tracings that we talked about before, that every little picture is different. This is just the more common one that we utilize. So let's play a fun game that most New Mexicans like to play called For Why. Okay. All right. Let's start with the interpretation of the P wave, the PR segment, the QRS, the ST, the T wave, and then a special one called the U wave. So starting off with the P wave. Now, we just said that the P wave is depolarization of the atrium, right? We're looking at those cells depolarize. Those ions move inside those cells. We have the right atrium and the left atrium that correlate to this wave. And that's really important because we can actually diagnose an incredible amount from both the the amplitude and the shape of this wave, and it correlates to both the right and left. I thought that was really cool. But then after we depolarize these, we're going to move on to a special segment where we hit this isoelectric line, and we go back to this isoelectric line where no chemical exchange is happening, but we are having atrial contraction. So when we have atrial contraction, we really don't see that much of a change inside the EKG. And then after we hit that atrial contraction, we're trying to get through that AV node. Remember, this is where a lot of that is interpreted. We're going to hit this Q, R, and S wave. Now, this QR and S wave have some special things that are really important to understand. Firstly, is that we hit this Q wave, and this Q wave, this physiological and sometimes pathological Q wave, is important in interpretation because remember I said it starts from the left side of the septum of the myocardium and then diffuses outwards through the Purkinje fibers, but it first hits that left side and then moves through that. And if we have a lot of scar tissue through damage, it could actually be elongated to like out here because it's having a hard time passing through that arena, that muscle cell. And so we have septal depolarization. And then after we have septal depolarization, we have ventricular depolarization. Remember that large amount of sodium that's traveling, shooting inwards. We're seeing this large dramatic change, and we're seeing them sort of start to begin to diffuse through the Purkinje fibers. But something that is masked, like we mentioned before, is atrial repolarization. It's sort of hidden by this giant dramatic change. Now, let's continue. And the button I kept pressing before, sorry about that. We go through this S wave. That's the Purkinje fibers firing up through the myocardium, and then we're back at this isoelectric line in uninjured hearts. And what happens is ventricular contraction. Remember, with atrial contraction, we hit the isoelectric line. Well, with ventricular contraction, we're hitting the isoelectric line again. So when we hit the isoelectric line, actually repolarization is starting at that time. So we're done with depolarization. We have ventricular contraction, and then we're going to hit a repolarization. So we got ventricular contraction right here in this ST segment. That's going to be important later. This ST segment after the QRST wave right over here, this ST segment. Now let's check out this T wave right here, because this T wave is incredibly important. So it's actually split up into two sides. The front half of the T wave is the absolute refractory period, and the bottom is the relative refractory period. This is the section that's sort of open up for damage, and that we need to be really careful that we don't have R on T phenomenon, and we can go into some crazy rhythms if electricity were to happen in this part. That's why we sync up things. That's why we, try to, not have PVCs as much, because we don't want to have this R on T phenomenon. That's why it's something that we commonly check. So something that you should be asking yourself, something that's a little weird, is that we just said that depolarization in the ventricles happen right here, right? We have depolarization of the ventricles. Well, why is repolarization of the ventricles, why is that positive? How is that happening? Repolarization, the electrical chemical gradient should be happening the other way, should it not? And that's something that really puzzled me. Why is that T wave straight up? Why is it up? Shouldn't it be inverted? How is that even working? Well, something that I again learned through making this PowerPoint is that ventricular repolarization actually happens a little weirdly. It happens from the outside inwards. Now let's break that down a little bit better. So I got this snapshot from the Khan Academy over EKGs. I strongly suggest you guys go check out the Khan Academy. Just type in EKG. It has a great layout of it. But remember, when we look at from depolarization, we're looking from the inside out. So we have this depolarization happening in this direction. We have this vector going from the negative to positive side. And when we hit repolarization, so now we're fully depolarized, when we repolarize, we actually work from the outside in. So we work from the epicardium to the endocardium, and that creates the same vector of the depolarization. So I just found that fascinating, that these muscle cells fire from the outside in and repolarize, not how we would think from the outside, excuse me, from the inside out, but from the outside in. So they depolarize from the inside out, and they repolarize from the outside in, creating the same vector. So when we see that electrochemical change, it actually happens in a positive reflection, in positive manner. Okay, so remember that we're looking at potassium through this, and that sodium potassium pump. That's incredibly important. So moving on to the last segment of this wave, the U wave. Now, not a lot is known about this, and in the pre-hospital profession, not really utilized a lot. This is pulled from A Life in the Fast Lane, and has to do with repolarization of the Purkinje fibers, after potentials from mechanical forces of the ventricular wall, but it is utilized in a lot of different diagnoses of some pretty cool pathologies. So that really covers the tracing of the EKG. We only have a couple more videos. You guys are doing absolutely amazing, and I will see you guys on the next one.